we're here to talk today about using routinely collected data. I'm going to just tell you what I'm intending to cover so you can make sure that we're all have the same expectations. So we're going to start from a basis of not expecting you really to know anything about routinely collected health and care data, and we're going to kind of work up from the beginning. So we're going to start by talking about what we mean by routinely collected health and care data and spend some time exploring the formats that data comes in, where it comes from, and just a little bit of interactive stuff around that. And then how is this different from other research data that you might have already used? What additional skills and understanding do we need to use it? On what legal basis can it be used, and how does someone get access to it? Often getting access is actually the hardest part of a project. The types of data sets that are available among ARC researchers, how long it takes to get them, how much it costs. Whether, if we're collecting data ourselves, whether we could link this kind of routinely collected data to expand our studies or follow-up outcomes. And then Imogen is going to walk you through an example study that she's carried out in the last year using linked routinely collected data with some learning points from that study. And then I'll leave you with a link to all the resources we've made available to help you get started. So I'm going to work through each of those questions in turn. So what do we mean by routinely collected health and care data? Okay, so what we mean by routinely collected data is data collected in the course of patient interactions with the health service. So we might call it routine data for short, but we need to keep remembering that in a lot of interactions with the health service, there's nothing routine there for the patient. These might be quite unusual, worrying, or difficult times. And therefore, we need to be really sort of respectful of this data. So data can come from primary care. So that's part of the health service where you can make a direct appointment to see somebody. And the most common source of data from that are GP records, which I'll go through in a minute about how they're created and what kind of bits of data we can have out in order to carry out research. But it's mainly the prescriptions and the coded data. Then in secondary care, which is generally hospital data, mental health care, and some nursing, we can get data from episodes of care that happen in the emergency department, the outpatient departments, or from inpatient stays, and also some discharge summaries. Now you can see in this slide, I keep putting unstructured, and that means that some data that gets recorded about patients is just in the form of plain English language written notes. And they're treated quite differently from coded data, and I'll come on to explain codes in just a second. We've got mental health patient notes and some coded data, some nursing records, and then there are also disease-specific or tertiary care registries. For example, if anybody gets diagnosed with cancer in this country, it should legally be reported to the National Cancer Registry. And therefore, there's a full database of all the cancer diagnoses and treatment information. There's one for myocardial infarction, so heart attacks, MIs, that's called MINAP, that one, and various things on infectious diseases. And the other thing we're working towards, but it's a bit packed at the moment, is social care data, which, if provided by local authorities, should be able to be linked to NHS data on the basis of NHS numbers. So if you're thinking about a whole health service in an area, such as Sussex, which is where Imogen and I are based, you can link together now data from all those different providers, primary care providers, hospitals, community care provision, mental health provision. And this is now a statutory requirement of integrated care systems, which are kind of umbrella organisations over a geographical region of NHS providers. And in Sussex, this has been taken really seriously and has resulted in the creation of the Sussex Integrated Data Set, where loads of rows of data are being fed in to be linked together, and all of the data that is fed in has all identifiers removed. So names, addresses, dates of birth, and all of those things, and everybody in there, you can track their data using a pseudonymization key. I'll show you how that is legally hosted and protected in a little bit. I keep talking about codes. So the way that data is fed in here is through structured pieces of clinical information, and there are several different ways that clinical information is structured. One of these is called ICD-10, and ICD stands for International Classification of Diseases. All the hospital data in the UK and some of the mental health care data, and also data collected in other healthcare systems around the world, because this is an international classification, use ICD codes. So they have a stem, so a letter, letters S means something to do with injury. So this stem means a fracture of the forearm, and then you can have these additional codes on the end. So 5 tells you where it is, and 21 what kind of fracture and which side, etc., etc. So you get these alphanumerical codes appearing, and they relate to some plain English clinical concept. And those are the things we can extract out. Here's another ICD-10 code. So S is a category for injuries. S86 means an injury of muscle, fascia, and tendon at lower leg. So it's not a bone fracture. And so this is talking about the strain of a right Achilles tendon. And then we've got some other extensions. So you can see this kind of coding system allows for a really broad range of diagnoses that can get more and more kind of detailed as you add more bits on the end of the code. But you can, because it's a kind of branching tree of codes, you can also try and find all the codes, just the stems. So any lower leg injury would come under S86. Kind of nesting code system. You'll start to understand why it's really important to understand your coding system when I come to try and get you to make a code list in a minute. So that's hospital codes. Unfortunately, GPs code using a different system. GPs can code problems and symptoms that you come in with, but they also want to know a lot more about social context, history, family history. They might also want to sort of talk about action plans, treatments, referrals, but they might also note down things that they've discussed with you but decided not to do, or advice they've given you. They will obviously want to record diagnoses and test results. And so they have an even broader range of codes than ICD, and these used to be called READ, and they're now across primary care in the UK transitioning to something called SNOMED codes. If you think this is a pretend GP record for me, completely pretend. So there would be sort of long-standing information about me that might change, but is likely to stay roughly the same for at least a good few months or years. Known allergies, for example, might stay there for a while. And then if I go in and say I'm having pain and stress, they have the choice. They can either code a diagnosis or a symptom, or they can write about it in the free text here, or they can do both. So they might code a few things, and then they might add some sort of context or reminders for themselves in the free text. Now, because they could be writing all sorts of personal things in the free text, something like the Sussex Integrated Dataset only takes the codes. So I just want to be clear on that at the beginning. Now, just so you get a feel for how broad this coding system is, we're going to play a game. So I'd like somebody to, I might pick on someone actually. What we're going to do is guess the fairy tale from the READ codes, okay? So what I want you to do, I'm going to pick on the audience. She won't mind too much, I hope. Could you give me a number from 1 to 8, please?
Sure, let's go with 4.
Okay, do you want to guess the fairy tale, or should we ask for another card?
Let's go for another card.
Okay. I don't want to pick on somebody unsuspecting, but could you choose a number?
6.
6. Black magic. This is an actual READ code, okay, everybody? Any guesses yet? No? Okay, who else would like to have a go? No hands up. Choose a
Number one. Yeah,
Number
number one.
one. Female baby. Imogen, can you pick a number?
7.
Oh, did you say 7?
Yeah.
Return to pre-existing consciousness level. Okay. Imogen, another number?
2.
Concussion with more than 24 hours loss of consciousness. Can anybody guess the fairy tale yet?
Is it Sleeping
Sleeping
Beauty?
Beauty.
Yeah, very good. A spinning machine, I think, would have given it away straight away. So if we go to the next slide, you can see how, it wasn't me, by the way, but a colleague constructed the Sleeping Beauty story using read codes. Female baby, black magic, accident caused by spinning machine, excessive sleep, contact with plant thorns, spines, or sharp leaves, occurrence at other specified place, concussion with more than 24 hours, loss of consciousness, manual resuscitation, return to pre-existing consciousness level, and married, which it seems to be how every single fairy tale ends. So that's just a bit of fun to show you that the range of codes that you need to choose in order to define your clinical concepts is really broad. And we're going to look at that a bit more in a few minutes. But before we get onto that, I just want to talk about unstructured data. So I've said that none of this goes into the Sussex Integrated Dataset, for example. There's also a dataset in Kent that's very similar, again, doesn't host any free text. And one of the main reasons for this is that de-identifying free text, so taking out all identifiers, names, dates of birth, addresses, is much harder than structured data. So clinic notes, like I showed you, don't necessarily have a lot of names or addresses in, but a lot of letters and reports have them in everywhere. And there's some concern that even if you can train a really good computer algorithm to take those identifiers out, privacy risks remain because there's sort of unique combinations of events discussed or unique social context. So for example, if you're looking at discharge letters about somebody going home and it talks all about what floor they live on in their flat and who looks after them and that their lift's not working, and all these things could make somebody identifiable. And therefore data custodians are usually very cautious about sharing text data. The other issue is that unstructured data needs a lot of pre-processing to structure it in order to do statistical analysis. We don't usually want to sort of take 12 patients and read all their data and do a qualitative analysis. We want to structure it up in a way that we can do analysis over thousands of patients. So AI is obviously developing really fast. The ChatGPT and its subsidiary AI systems have been a real game changer in this branch of computer science called natural language processing. For Kent and Sussex mental health data, which is mostly unstructured, so if you go into the mental health service and have a consultation, the clinician will write mainly just free text clinic notes about the consultation. And these are uploaded securely to a data safe haven hosted by a company called Acrivia Health. And they use something called the CRIS system to provide AI to structure that data and pull out the clinical information that is wanted. Diagnoses, symptoms, and medications. So at the moment, the Sussex data can be applied for. You would get a login to use it. I've put the details here. So just to show you the kinds of jobs that AI needs to do. Imagine that word appears and we're looking to see if there's any information. Do we think that person has information? Well, we need to look all around that word because, clinicians will do a lot of safety netting around, I've ruled out this, I've ruled out that, I've ruled out the other. So we need to be able to make sure whether something is negated or not. AI needs to be able to read and decide even slightly unclear examples of negation. He denies being a smoker. Is he a smoker or is he not a smoker? He denies it. This person have diabetes? well, no, actually, it's their mother that had it. So we need our AI to be able to tell who is the experiencer of the symptom or the diagnosis. Is this person currently taking sertraline? No, he stopped taking it last week. We also need to know time or history. Is this now or is it in the past? And does this person have rheumatoid arthritis? Well, symptoms suggest it, but that's not an actual formal diagnosis. So we need to also look at the level of uncertainty. So you can see that actually getting clinical information out of unstructured text and turning it into usable data for analysis it's a complex task. And that's why Sussex Partnership employs a whole company called Acrivia who just specialise in doing that, to do this job. I have also worked with specialists in the informatics department of the University of Sussex who do this kind of work as well. Okay. So I've run you through the types of data available, and I want to talk to you now about how routine data is different from other research data and what additional skills and understanding we're going to need to develop in order to use it. You've got to remember, and this is really fundamental to understanding the kind of extent of use of routine data, that you've got a patient with certain symptoms. They don't speak to the clinician. So there's an exchange of information between the patient and the doctor, let's say. And then the doctor filters that information in her head and then decides what's necessary to record on the computer. So at each point, there's going to be a drop-off of information and a filtering and a prioritization of information that gets put in the computer. Now, we extract out the codes. That's our easiest bit to look at as researchers. We don't know what drop-off or changing of information there's been in this exchange between patient and clinician, and we don't know the drop-off or exchange of information that the clinician has filtered when he's decided what to put in the notes. And we don't know how much has gone in the codes and how much has gone into the free text that we might not have access to. We need to consider, when we're thinking what's in the data and whether it's good for our research purpose, the constraints on what data will get entered by a clinician. So we've already talked about the coding structure. Now, how flexible is that, or what limits does it put on what whether the doctor can code up what they think is important? Also, how easy is it for them to use the patient record system? Some interfaces will prioritize people writing in text, and others will really help them code data, in which case you've got much richer coded data coming out the other end. You've got to think about the time available. How much time have they really got to document carefully everything, all the information coming into them? And then also considering the motivation for documenting. So in the hospital, things are coded in order to reclaim money through the NHS from the government, so for billing purposes. But in primary care, it might be more a record for the own memory. There is also some financial incentives to record things in a particular way. And there also might be some sort of medico-legal safety netting. People are recording what happened in case anything negative happens later on. There's clinical reasoning and filtering of information, as I said, trying to decide what's the most important thing to put down. And there's usually, in the course of a busy clinic, little consideration of secondary purposes. So just keep this in your mind when you're thinking about the data that will be used. So the data gets extracted out from the clinic environment into usually a data safe haven, which we're now calling secure data environments, or you might also hear the acronym TRE, Trusted Research Environment. And when it's provided for research, nowadays you mainly would get a login into a workspace within that trusted research environment. And the data provided to you would be on the basis of a protocol application, and then it would be provided to you on the basis of exactly what you need for the protocol of the research study that you've had approved. Usually when you get access, you'll find there's one row for each patient encounter with the system. So with a date stamp and usually a clinical code of some kind or a prescription code. One patient, therefore, if they've got a row for every encounter with the system, could have thousands of rows, each one with a single clinical concept. So how do you know if that patient should be in your study cohorts? You need to define up front which clinical concepts define your condition that you're interested in. So say you're doing a lung cancer study, such as Imogen's going to present to us in a bit. You need to define up front which of the codes out of the 200,000 possible codes mean that person's got a lung cancer diagnosis or a diabetes diagnosis or dementia or whatever you're interested in. You need to decide, is there a study period in which they have to have that code? And on what basis might I exclude them if they've got other conditions? So those diseases and conditions are usually defined by a list of codes representing a firm diagnosis of the condition. So just before we come on to an activity that I'd like you to do, I also want to talk about what statistical skills you're going to need. So generally for these long lists of data, you're going to need to do a lot of pre-processing to get it into an analyzable format. And so far, people I work with have found Stata, R, and Python to be useful software for doing this data pre-processing and the final analysis. And Imogen has done quite a lot of transformation of things into SQL, which I might mention in her talk. Be prepared for lots of months of data processing, merging in code lists, checking cohorts, excluding outliers, and using lookup tables, etc. You might need to understand how to reformat data from a long form where you've got a row for every encounter with the system into a wide form where you've got one row per patient with all their information in one row. So that'll make it really much easier to analyze. And then you can download packages to run particular statistical tests like a regression and interpret the outcomes. Now, if that seems really scary, one thing we're doing on our Data Hub website is kind of find and advertise training courses where you can go on a short course, like a week long, and learn these skills. Okay, so let's do a little exploration task. If you can sort of minimize or shrink the Zoom screen and bring up a web browser, I would like you to try and find this website, https://termbrowser.nhs.uk/?. Now, this is a code browser for SNOMED codes. So if you can click on the bit that says go browsing, and you should find a browser screen like this, and then you click on this tab top left that says search. So this is just to help you explore and start to familiarize yourself with a list of codes. So what I'd like you to do is choose one of these cancers, prostate, ovarian, or esophageal, and start searching, see how many codes you get. Now, not all of them will be diagnosis codes. Some of them will be family history, some of them will be patient history, some of them will be treatment codes. And you can't just search prostate cancer because there's various different synonyms. There's things like neoplasm and carcinoma you might want to search as well. And then you don't have to choose those particular diseases. Choose a disease that you're interested in. And then if you can type in the text the disease you chose and the number of codes you think you found, which would represent that, as if you were making up a code list. Just the number of codes, you don't have to list them all. Yeah, just to help you familiarize with the idea of the concept of having to determine what's in and what's out. So now you are familiar with, diabetes 670, angry. Oh no, how are we ever going to refine that as a code list? So anyway, you can see making a code list and defining your concept is a complex task, and I don't think 5 minutes is enough to create a code list. So I've just answered my own question. I would suggest some advice on making a code list, but it's fundamental to your research. It's defining the concepts, the patient group, the outcomes or the exposures that you want in that group. Always consult a clinician, one that works in the service of whose data you're using, to get more guidance on what should be in and out of your code list. So for example, I did a dementia study and included a code on delirium. And of course, as soon as I spoke to an old age psychiatrist, they were like, that shouldn't be in here. That's not a dementia diagnosis. That's a diagnosis of exclusion. So of course that went out. So, you know, they will help you refine your code list. And Imogen has created a code list resource to help you think about the issues. If you go to our ARC Data Science Hub, the link is here. You can click on down the side, Beginner's Guide for Handling Routine Data, and there's a guide for developing clinical code lists, which we'll download down here. And remember to think about other conditions of exclusion and different synonyms and ways of saying something. Okay, let's crack on with the next topic, which is under what legal basis can routine data be used and how do we get access? So the lawful basis of processing data in this way is determined by the data protection legislation. Everyone likes quoting GDPR completely falsely, but in this case, that is what we're using. So data protection legislation requires that the collection and processing of personal data is fair and lawful and transparent. There are two lawful bases of use of patient data. One is by getting people's consent, and the other one is a task in the public interest, which does not involve consent, but has to be coupled with data minimization, which means that you don't take data you don't need. And using patient identifiable data for anything other than direct care is very highly restricted. So all data that we would use would be depersonalized or de-identified. That means identifiers are taken out. So no patient should be identifiable from the data being used. In any case, because you've got what is sensitive and personal data, even if you don't know who it belongs to, it is kept securely nowadays in a data safe haven. Other names for this are a secure data environment or a trusted research environment. This means the electronic data is kept on computers in a secure place, and analysts who come from health or social care, from universities or other approved organisations can make a data access request. This is assessed against a set of rules, and then if their data request, their purpose for using the data is approved, then they get access. So they will get a login into the computer environment where the data is stored. The data is not sent to them, they come to the data. They do their analysis. They create a bunch of outputs like graphs and data tables, and those are then assessed against the rules again to make sure that they're all aggregated data, nobody can be identified, and then those are allowed to come out and be put into research papers. One of the reasons we don't ask patients for consent is that although consent would increase patient autonomy, it places a high burden on patients and the healthcare system to secure that consent. And it's likely to introduce bias because the only people who would consent are a small portion of the population. You've got to start thinking about who would opt in and who would be left out. And it's very likely that with an opt-in system, underserved and seldom heard populations might be missing from the data. If this is something you feel strongly about and want to opt out, you can do so at this link, nhs.uk/your NHS data matters. What types of data sets are available and how long does it take? How much does it cost? Now, there are a lot of data sets available, more becoming available all the time. Rather than go through each one, I'd like you to explore our resource on this at the ARC Data Hub website. We've started uploading resource packs on all the data sets that we've been asked to give advice on so far in the Data Hub. A lot of these are housed under NHS England. It used to be called NHS Digital, but now it's NHS England. And we've also got a data pack here on the Sussex integrated data set. We'd be happy to make one on the Kent data set. Surrey doesn't have an integrated data set. And we will shortly be putting up information about how to access the CRIS data that I talked to you about, the Acrivia process and make available. So if you click on that link, you'll get to be able to download Katie's resource pack. Katie is our coordinator in the Data Hub, and she's made these brilliant packs for everybody and made them publicly available. So, for example, if you want to get hospital data on hospital episode statistics, the resource pack will give you the key contact details, a data dictionary link so you can see what variables that data set contains, a guide on how to access the environment, the data environment you would log into, and the application process. What kinds of contacts and data sharing agreements you would need, how much it would cost, and any training or accreditation you would need to secure before you apply. You have a play with that after this. Another question I get asked quite often is, can we link NHS data to our research data set? So if you've recruited patients into a study and you have their data, and then you sort of later think, oh, I could follow them up more long term with their medical records. Unfortunately, this is not as straightforward as it sounds. So what you need to do then, if you've got consented patients and you want access to their particular medical records, you would need funding to access or extract their individual records. You would need their consent, and then you would need to approach individual trusted providers to give you that patient's data. The reason is the big data sets, the linked data sets, they're so robustly de-identified, we can't tell which patient is in your study in these data sets. And we're not, at the moment, the data set is not allowed to host identifiable patient information, so we could re-identify them. Some data hosts, like NHS England, NHS Digital, do have permission to hold patient identifiers securely and to perform a linkage for you at a cost. And some research cohorts that you may have used in the past, like the 1958 birth cohort, or nationally held birth cohorts like the Bristol one that's called ALSPAC, are now being linked to their medical records. That's worth going and looking at. There's a big collaboration called the Longitudinal Linkage Collaboration, which is making all of those big longitudinal research studies link up with those participants' medical records. And the director of the UK Longitudinal Linkage Collaboration is actually coming to BSMS on the 3rd of July to give a talk, so everybody's welcome. So I'm going to skip through these slides and pass straight over to Imogen to talk about the study that we've done as part of the ARC Data Hub.
I'm just going to talk through how we went about a project using routine data to look at cancer risk stratification. So there's been evidence accumulating that cancer diagnosis may be delayed if the patient has comorbidities, and it's been suggested that there might be a few mechanisms explaining this, one of which is competing demand, which is where the patient has conditions that are unrelated to the cancer but place demand on the clinician's time. And also alternative explanation. So that's where conditions are present that might provide an alternative explanation for cancer symptoms, and so delaying cancer investigation. So there was a paper from Mount Siddle a few years ago looking at delays in colorectal cancer diagnosis, which classified the conditions the patients had into these two classes, that is alternative explanation and competing demand conditions, which found that both types of conditions delayed diagnosis, with the longest delay for a single condition being for inflammatory bowel disease, which delayed colorectal cancer diagnosis by 26 days. So in this work, we investigated the effect of possible competing demand and alternative explanation conditions on lung cancer and mesothelioma diagnosis, and also looked at the effects of measures of inequality or index of multiple deprivation and behavioural variables, so smoking, BMI, and alcohol drinking. So the data set that we used was the main data of the Clinical Practice Research Data Link, or the CPRD. So this is a big pseudonymised primary healthcare records database from around 20 million people. So the data sample that we were given access to is for 800,000 patients in England who had data up until the age of 65 years. So the data is held in a series of different text files. So there are clinical and referral files, which have information on diagnoses and referrals, additional files, so that's extra things recorded during the consultation, like information on height and weight and smoking, therapy files where prescription details are stored, test files, so information about any test orders and results, and patient files, which have information about the patient, like sex or year of birth. So we also had access to a number of linked national data sets, so the hospital episode statistics and the cancer registry, Liz mentioned earlier, information on the index of multiple deprivation, which was based on the postcode of the GP practice, and the ONS data, death data, which had information on the patient death date. So our outcome variable was diagnostic interval, which we defined as the time between the first presentation of the patient in primary care with a relevant symptom and the date of cancer diagnosis. So that was taken to be the earliest date of a diagnostic code for lung cancer or mesothelioma in the primary care records, or the hospital episode statistics, or the cancer registry data. So the earliest across those three. The presenting symptom date was taken to be the earliest date of a relevant symptom code appearing in the primary care data. So we included 8 symptoms based on the NICE guidelines for cancer referral. And we took the relevant time span to be the 12 months prior to cancer diagnosis. So the code lists for the symptoms were drawn up by searching the clinical code browsers, which were supplied with the CPR data, reviewing published code lists, and then discussing that with a GP to make sure that all the codes were relevant. And we also looked at the effective consultation frequency, both in the 12 months before diagnosis and from 24 to 12 months before diagnosis. So the comorbidities we considered as alternative explanation conditions for asthma, COPD, having a prescription for an angiotensin converting enzyme inhibitor, because this can cause cough in some patients, and chronic fatigue syndrome. And we also considered 9 chronic conditions such as coronary heart disease and diabetes as possible competing demand conditions. So we defined these by the presence of a diagnostic read coder. For most of these, this was at any point in the medical record, so in the clinical referral files, and this is on the basis that they were chronic non-resolving conditions, with the exception of depression or anxiety, where we just looked at codes in the last 3 years because it can resolve, and ACE inhibitor prescription, where the last 2 years was taken to be the relevant time period. So yeah, this is just a bit of information on how the behavioural variables were defined. So these are all based on read codes for smoking, BMI, or alcohol drinking status, which could be present in the clinical referral files, or we also used information in the additional files on height and weight, or BMI measurements, or information about cigarette or alcohol consumption. We used the most recent data available, excluding data from the last 6 months before diagnosis, on the basis that that might reflect changes in behaviour due to cancer symptoms. So the analysis method we used was multiple linear regression model, with the outcome being diagnostic interval in days. So our initial model included the competing demands and alternative explanation conditions, consultation frequency, the behavioural variables in IND, and we also put in age, gender, and year of diagnosis. So a final model was selected by stepwise selection based on AIC. So we had complete data available for around 10,500 lung cancer and mesothelioma cases. And we found that diagnostic interval was increased in patients with one or more alternative explanation conditions. So it was nearly 28 days longer if they had a single condition, and 72 days longer they had 2 or more conditions. And the longest delay looking at the conditions individually was for COPD, which delayed diagnosis by 60 days. So the number of competing demand conditions didn't remain in the model, but consultation frequency was strongly positively associated with diagnostic intervals. So that suggests that demand on the clinician's time could be playing a part in this. And we also found that diagnostic interval was increased among ever compared to never smokers and in underweight patients. So that suggests that other indicators of poor health or unhealthy lifestyle may be delaying diagnosis in these patients. So this is my first main bit of analysis using routine data. So some of the lessons I learned that firstly, as Liz said earlier, you really do need to allow enough time for data preparation. It's really easy to underestimate how long that will take, and the great majority of the time on any kind of project using this type of data is going to be taken up with preparing the data for analysis. These data sets are really large, so that can cause issues with using some software. I generally use R, and that can struggle with really large data sets, although there's some workarounds. That's something to take into account. You need to check all the code lists you use. There are published code lists, but it's quite common for them to contain errors or to need updating. There may be quite a lot of missing data. So that's particularly true for things like BMI and ethnicity. and you need to give some consideration as to how to deal with that, because it's unlikely to be missing completely at random. You tend to get a phenomenon whereby the patients who are sicker tend to come in more often and have more things measured on them. So you need to think about what kind of strategy you're going to use for dealing with that, whether to do a complete case analysis or to find some way of imputing those missing values. And the other thing is, in terms of defining the variables, you have to think about what sort of time periods include data from, whether you're just going to use diagnostic codes or also try and pick up extra patients with conditions by including medications. So it depends how sort of inclusive or precise you want to be. And the fact that you're going to have multiple sources of information at multiple time points on the same thing, which may conflict. So you need to consider how you're going to deal with conflicting information and what sources of information to prioritise. Some of the resources that are available. Working with routine data, there's various clinical code list repositories. So, for example, the HDR UK Phenotype Library. There's one at the London School of Hygiene and the universities of Cambridge and Manchester. So they're a really good first place to look for any pre-existing code lists. A lot of the algorithms that have been used to define variables, particularly in the CPRD, have been published. Stata is very common language used for doing that, but there's some more stuff becoming available in R, and there's also various Stata commands and R packages for dealing with clinical codes and for working with electronic health records becoming available. And there's also various training courses, some of which Liz mentioned earlier. The MHRA do a course on working with the CPRD data, which is very good and really worth doing. And there's also various safe researcher training courses and various courses available on working with routinely collected health data at UCL and Swansea and various other places.
I'm just going to share one or two more slides. In terms of what resources are available to help get you started, this webinar should become available. It's being videoed. You'll have the slides to look up all these links, and we've lodged as much as we can on this website. So you've got the data set resource packs. We've got an email address to contact us. We're going to start doing clinics to give people advice. And there is now, as I showed you earlier, the resources around developing code lists that Imogen have created. So just scroll down through this left-hand menu and see what you can find. And that's the end of the presentation.